you know what? I need to post. Can you go down to participants? Just click it, and then it'll say Aubrey Good and you. Can you click, let me see. How do you do this? Can you click my name and then just put host?
Okay, make host.
Yes. Perfect. Okay. Here we go.
You see the taskbar down on the bottom?
No, I can't.
Okay, all right.
I can just see the PowerPoint. Okay, so we're gonna go on. Okay. We are going live, so I'm going to start the presentation now. Hello, everybody. Thank you for joining us today. We are here with Michael Pipich, who is a psychotherapist, lecturer, and media personality who has more than 30 years of experience in mental health. He's taught graduate-level courses in diagnosis and psychotherapy, psychopharmacology, and substance abuse and addictions. Michael provides national and professional trainings in bipolar diagnosis and treatment and conducts community-based bipolar educational groups for patients and families. He is the author of Owning Bipolar, How Patients and Families Can Take Control of Bipolar Disorder. Michael currently practices in Denver, Colorado. Thank you so much for joining us, Michael.
Thank you very much, Aubrey, and thank you to you and the International Bipolar Foundation for sponsoring this event and welcoming me, giving me an opportunity to share some thoughts and ideas. And to everybody who's watching right now, welcome to you as well. And thank you for taking time out of your day today and the things and responsibilities that are important to you to share this moment. And I hope that by the end of today's presentation that your understanding and an appreciation for bipolar disorder and what it can mean in a person's life will be enhanced. And hopefully some of these ideas that we share together today will also improve understanding within one's family and support system as well. So again, welcome to all of you. So the concept of owning bipolar is kind of where I want to start today and talk from there about the three-phase approach to bipolar therapy that I've developed and am teaching to clinicians as well as non-professionals in various places throughout the country, and thanks to the internet, many places now throughout the world. And I want to share some of those thoughts with you today. And all of this material is coming right out of the book, Owning Bipolar. So that's available, obviously, as well, and with perhaps some greater detail in some of the concepts that I'll be introducing here in this webinar today. And also know that by contacting me through my website, which is michaelpipich.com, you can send me an email with any of your questions and any comments or ideas coming out of today's webinar. And I'll be happy to look at those and reply to them. And I do make a habit of replying to my emails and various contacts that I receive over social media because I think it's really important to maintain that dialogue. So feel free to do that as we go forward, or if something strikes you after the webinar at some point, feel free to reach out and contact me. I'd be happy to see what it is that you're interested in, what your responses are coming out of this program today. So why owning bipolar? What is really the meaning of that concept? I have to confess it wasn't necessarily something that I came up without the help of people that I've been in contact with, mostly family members actually, who were either in my office for therapy for themselves or in couples therapy where their loved one had bipolar disorder. And I heard that more than once from individuals that I was working with who would say, you've got to own your bipolar. Or if they're talking to me, he or she has to really own this. They're not owning it, they're in denial and so forth. So I was kind of inspired by those individuals who have shared that concept and gave me some opportunity to think about what is it really to own bipolar. And I want to share some of those concepts with you today as to why the owning piece of this, I think, is so important. First of all, bipolar disorder, I think it's important to understand, is genetic in its foundations. About 70% of all causes related to bipolar are biogenetic. It's really coded in a person's DNA. And bipolar disorder is not something that kind of is the result purely of trauma or bad parenting or anything of the like that could create other kinds of problems in a person's life, including clinical depression, anxiety, and so forth. It's important to understand again that bipolar disorder is passed genetically through family lines. And as a result of that, a person basically comes onto the planet with the foundations of bipolar disorder. And we can expect at some point in their lives certain catalysts occur that brings out the disorder in its symptoms. And we'll talk a little bit more about symptoms as we go forward. And I'm sure many of you are familiar with those symptoms, but we'll kind of talk about it and fold it into our conversation as we go forward. But I always talk about the causes as being both a predisposition, which is mostly genetic, and then catalysts, which include anything that happens within the body, like hormonal changes during adolescence, or what a woman would experience with respect to postpartum kinds of factors that can bring out bipolar disorder symptoms, or thyroid changes, or any kind of internal changes within the body, and also things of that nature that are the result of substance abuse as well. And then from these catalysts, we can, at some point in that person's life, the genetic aspect is sort of activated. All right. The other important aspect in terms of owning bipolar is recognizing that because of the genetic piece to it, having bipolar is nobody's fault. And I know that family members appreciate that too, particularly parents, or even spouses and loved ones and caregivers. Nobody caused it. It again, because of the DNA factor, it's something that a person carries with him or her through their lifetime. Here's another concept. You can't beat bipolar. And I think, by that I don't mean that in a positive way. I mean, it's a lot of people will say you can't beat mania, and I don't mean it quite that way. I think, particularly in this country, we think of things a lot in sports analogies and victory and defeat. And a lot of times we look at disease in general, I think, from that perspective, don't we? And bipolar disorder is nothing that you conquer necessarily. And the important thing is, I think, to not allow it to defeat you, but rather than beating it back or winning at the bipolar game, owning it is about understanding and accepting it towards lifelong management. When I work with families, very often a family member might comment that they're concerned that their bipolar loved one would use the diagnosis as an excuse for a bad behavior or impulsivity or substance abuse and so forth. And owning bipolar is recognizing that bipolar disorder as a diagnosis, as a concept, is used to explain what's going on or what has been going on, not used as an excuse per se. So owning it is about recognizing the explanation that bipolar gives, the context it gives to that person's life towards taking responsibility. So it really is ultimately about moving from denial of bipolar disorder in its existence in that person's life or in the family's life, and taking responsibility. And here's a very simple concept, I think, and important, again, in understanding what owning it means. That we don't look at a person who has bipolar disorder as themselves bad, okay? Now, all kinds of different individuals can have bipolar disorder. But fundamentally, I think it's important to understand that the person with bipolar disorder should be looked at anyway as a good person, fundamentally good. And it's the bipolar disorder that can change that person's behavior away from whatever their typical moral pattern would be, away from those extreme mood swings and what that can create in that person's life. And again, I think it's important for people around that individual to understand that we talk about bipolar disorder as itself, because it's a disorder and because it can do bad things, as bad, but separate from the individual who's trying to, in some way, cope with it in his or her life. As I mentioned earlier, it's important to move from denial to acceptance. And with respect to denial, I believe that everybody that has bipolar disorder and requires treatment is going to have some level of denial in their life. Not everybody it necessarily presents that in a severe way. In fact, some people are really grateful to know that they have bipolar disorder. I mentioned in the book that one woman I remember, when she found out that she had bipolar disorder, her reaction was, "Thank God, I thought I was going crazy." And in that, it might be a little bit ironic to some people, but what that really means, I think, is that she felt alone and she felt scared. She didn't know what was going on. That made her feel crazy in her mind. But the diagnosis helped her to kind of get her mind around the situation and recognize that other people share in these problems, and that she wasn't alone. So that was very useful. But many people, as I'm sure you may be aware, to one extent or another, begin their sort of bipolar journey into treatment at some level of denial, or the family members can be in denial as well. It's not uncommon with parents in particular, that they may resist in some way the idea that their child has a lifelong mental illness that requires treatment. But the important thing to understand is that this is part of bipolar. It does not reflect that the individual's own characteristics away from bipolar, if we can at some point separate those two in some way. Again, it's the person that's good and the bipolar that does the bad stuff, so to speak. And with regard to denial, we just expect that as a part of treatment. And we'll talk a little bit more about that as we go forward. And then finally, with regard to owning bipolar, we know right now there's no cure for bipolar disorder, but it can be successfully managed in a person's life. And I think that's the good news. And that's the good news we'll take into this webinar as we go forward as well. Now, we kind of finished with some positive stuff, and now I'm going to give you some facts that I call not so fun facts. But I think they're really important to kind of give us some context about what we're talking about today. And this is kind of a long bullet point in front of you, but I think a very important one. The research shows that the average time for an individual that has bipolar disorder to be from the time that they had their first mood event related to bipolar disorder to the time that they actually received the appropriate treatment for bipolar disorder is about 10 years. And what is happening in that time of 10 years or longer, because again, that's an average. So some people a little shorter, lots of people much longer. Well, a lot of damage can be done in that person's life, as I'm sure many of you are already aware of. But there's a lot of reasons why it takes so long for somebody to have their bipolar properly recognized, properly diagnosed, and properly treated. And I think that really kind of necessitates for professionals and non-professionals alike within our communities to really understand and be more aware of how we can recognize bipolar and help people to receive the proper care that they need. And as I mentioned, bipolar disorder is often undiagnosed or misdiagnosed as other disorders, primarily major depression without bipolar involvement, or what sometimes people call unipolar depression, or any number of mental health or relationship type issues. Substance abuse is particularly common. Over half of people with bipolar disorder have a co-occurring substance use disorder as well. And that substance problem often masks bipolar symptoms. And then the most unsettling, but I think important information, if you can bear with me, I think, it brings context to what we're talking about today. In bipolar disorder, suicide potential is 20 to 30 times higher than the general population. 1/4 of all deaths by suicide may be bipolar disorder related. In this country alone, that's over 10,000 lives every year. And another important fact to recognize is that there's an increasing risk with age when it's not treated or not being treated in a thorough manner. So the concept that people somehow mellow with age doesn't apply to bipolar disorder, unfortunately. It has to be attended to through the lifetime. With untreated bipolar, as many of you I'm sure are aware, there's a greater incidence of domestic violence, substance abuse, hospital admissions of all kinds, psychiatric and non-psychiatric, and an important factor, mania induced by psychotropic medications, primarily antidepressant medications, where no additional kind of medication is prescribed for mood stabilization, and also, not uncommonly, medications prescribed for ADHD. And most of those medications are stimulants, and that can produce a manic episode if we don't know that there's an underlying bipolar disorder involved. And something that we professionals, I think, need to do a better job of, frankly, and that is that we often miss presenting symptoms and historical data. Family history is very important for all of us to really understand if we're going to enter into an assessment, to understand what bipolar disorder, that it may exist in that person's life. So very often when people come to therapists like myself, they come with other presenting problems, not necessarily something that looks like mania or hypomania right away, that is more easily identified, but they can come in with recent depression or all kinds of life problems. And very often we therapists take that presenting problem and begin to work a treatment plan around that. But it's important to get all of the personal mental health history and family history to help reduce the likelihood that that individual be misdiagnosed and not properly treated. But here's another reason why bipolar disorder is not often recognized. Now, when you see this, either rather large bumper sticker or really small car, or both, what kind of concept comes to mind? Besides Kanye, because I think he kind of hijacked this concept recently that I've been presenting. But, and I don't think this is his car. I think his car is much bigger than this one. But I think it conjures up an idea that a lot of people don't want to let go of what they perceive as the beneficial aspects of mania, primarily a sense of increased energy, being alive, feeling like their senses are opening up. Maybe coming out of depression, it really is an important counterpoint to what they had been experiencing. So a lot of people don't want to let that go. They feel more creative, and as I mentioned, productive, either in their jobs or in their recreational activities, or maybe they feel very artistic and so forth. And some of those things are just really, really hard to let go of. But I think it's important to recognize that the perceived beneficial aspects of mania also come tied with what we describe as functional consequences, which are not so beneficial to that person's life. And sometimes they can sort of move through those things with in a particular episode with little or no damage, but when left untreated, they're very often going to meet some kind of consequence in their life, which is going to really put them in some sort of danger. And very often, of course, loved ones around them are the first ones to recognize what that may mean in that person's life. So owning bipolar together means that we all have to collaborate together. People with bipolar disorder, the family members, treatment professionals, and the larger community, and organizations like this one, the International Bipolar Foundation, are very, very important to cast a much larger light on the need for all of us to kind of work together and to be able to recognize bipolar disorder and own it together. Before we go into talking about the three-phase approach to bipolar therapy and the features in each phase that I think you'll find interesting, I wanted to take a moment to mention what I call the 7 bipolar mood zones. And again, this is presented in the book with some greater detail. So if you're interested in that, by all means, take the opportunity to look into it. I think it's very important. And the reason why I talk about mood zones as opposed to simply mood episodes, from a clinical standpoint, we talk about mood episodes, but when I'm helping patients and families understand bipolar, I talk about mood zones. And the main reason is that I found that oftentimes people with a disorder or people dealing with it within their family context can think that when a person is not in an episode of mania or hypomania or depression, that they're fine, that they're okay. And they may go so far as to believe that that person no longer has bipolar disorder, or they're somehow cured, or they're going to be okay, and no further problems are going to happen. What I describe instead is that a person is simply in a different zone, and that bipolar disorder is something that, as a mental health problem, is persistent over that person's lifetime and requires treatment, even if they're not presenting symptoms or in an episode. They're simply in a different zone. And if you notice on the slide, the middle zone is called baseline. And I avoid talking about feeling normal, because a lot of people describe their normal in all kinds of different ways. And I think normal is kind of a bad word. It's good for statistics. It's not necessarily good to describe a person's emotional state unnecessarily. So I just call it a baseline. And then when we're talking about treatment and how a person's feeling from time to time, are they in their baseline, or are they sort of out of the baseline into some of these other zones? And I wanted to point out in particular the extreme zones, the ones that start with the word psychotic, mania and depression. Those are the worst forms of bipolar mood swings. And they very often, along with, in terms of the manic side, the increased energy, sense of euphoria, or high levels of irritability that we call dysphoria, they can experience hallucinations and delusional thinking, sometimes very paranoid, sometimes very, very grandiose, way outside of a sense of reality. So those are the worst forms, very often requiring hospitalization and intensive treatment to bring it down closer to the baseline. Sort of in the middle of both sides of the red and the blue, those zones can be obviously very troubling as well. They're not necessarily less of a problem in themselves, but as you can see around baseline, sometimes people who are stabilized on medications can experience some hypomania a little bit, or some what we call dysthymia, which is sort of like minor depression, a little bit of the blues, some anxiety, but nothing by itself that would perhaps be alarming, but may need some treatment adjustments. So what I do often for patients and families is give them an opportunity to sort of chart their mood zone so they become more conscious of where they exist in any given time, day, or week, or if they're going through some particular stress at school or work or in their relationships, or they've experienced a recent loss. Maybe in some way it's a good time for them to sort of reevaluate what zone they might be in or where they think they may be going so that we can do some adjustments with their treatment. So now we're going to talk about the three-phase approach to bipolar therapy. And as I mentioned, I developed this primarily because I don't think I mentioned why I developed this, just that I did. So I'm going to tell you why I did. I believe that coming out of a few decades now of treatment for bipolar disorder, which has been pretty much limited to medications only, that we kind of lost, I think, in our in the treatment community, a real unified way to help people to understand what bipolar disorder is and what to expect as they go through that treatment process with medications, but not exclusively because of those medications. And I had many great teachers and many great mentors that I'm forever indebted to. But when I was coming up as a therapist back pretty much in the 80s, the lithium revolution was still kind of a hot topic. And for a lot of therapists at the time, primarily psychoanalysts, they were really converted in believing that talk therapies were essentially useless for people with bipolar disorder, and that lithium, and then a little bit later of the anti-seizure medications that are developed for epilepsy and seizure disorders, were found to be so effective compared to talk therapies that talk therapy, psychoanalysis, and all the various kinds of psychotherapies were unnecessary. So there was a real pendulum shift from kind of psychoanalysis to just get them on meds. And I actually heard that frequently when I was working in hospitals and so forth. All you can do is with people with bipolar disorder is just get them on meds. And I don't believe that. Thankfully, most of my colleagues, I'm sure, don't believe that anymore. But as a product of that, that sort of conventional concept at the time, I think a lot of us therapists sort of got lost in terms of what we were supposed to do with bipolar disorder, and I think that helped contribute to that 10-year gap in treatment that we talked about. So I'm presenting this today to you, even if you're not a professional. It's okay, because I think you'll find in this part of our talk today some real gems, some real features that perhaps you can relate to either within yourself or again with a loved one. So the three phases are thus. The first one is pre-stabilization, and that's about treating the bipolar symptoms. The second is stabilization, which is about treating bipolar disorder. Now, the difference between the two is that I think it's important to separate symptoms. So we talked about earlier, a lot of people who have bipolar disorder kind of hang on to those beneficial aspects of the disorder. So if we just say, hey, you have bipolar disorder, they may say, okay, great, I kind of like some of that bipolar disorder. I don't like all of it. If we kind of break it down into symptoms or different components, we can better communicate what the non-beneficial aspects of the disorder is all about, and help people to begin to think about treating the things that they don't like about their bipolar, like depression and some of the parts of mania that can be very, very uncomfortable, like the irritability and agitation that we see in dysphoria. When you move to stabilization, which is centered around medications, but also to help the individual and the family kind of stabilize in a social sense, then we can begin to weave some of those symptoms together and talk about bipolar in terms of the whole concept. And then as they move through that phase, they go into the third phase, which is post-stabilization, which is about treating the whole person, not just about bipolar disorder, but whatever the person in his or her life is troubled with, suffering with. Certainly, very often, that those are the consequences or the effects of bipolar, kind of going back and maybe repairing some of that damage, but also going forward and thriving in their life to become creative, productive individuals and understand their own emotional life and what that really is meant to be all about, apart from bipolar disorder, since bipolar disorder was really dictating how that person should feel in particular situations. Now it's about reorganizing so much of that in that person's mind and developing a new identity through that so that they get to know what a true emotional experience is all about. So a lot of bullet points here, so we'll just kind of go through that. Some I already presented to you, but just to kind of help understand why we have three phases. It's centered around the medical stabilization of bipolar disorder symptoms. That's what BD means here, by the way, bipolar disorder symptoms, but it's never meds only. But medication is a very important part of it, of course. A collaborative approach to medication issues. So people talk together, patient, family, therapist, and of course, prescribing physician, about what medications are. It's not just about, hey, we're going to give you medications. We're going to have an intelligent, meaningful conversation about those medications to, among other things, educate and alleviate fears and help through the denial. Again, we expect to be a part of bipolar, particularly in that pre-stabilization phase. Working through denial towards acceptance, of course, accepting the chronic mental illness aspect of bipolar and associated identity issues. I mentioned that a little bit. We're going to talk a little bit about it in that post-stabilization phase. And then engaging family through education and support. Not everybody wants to have their family involved in their treatment, at least not right away, and that's understandable. But I have found, and research has backed this up many times over, that with the right family members, and not 20 of them, maybe 2 or 3, ideally at least one, who is involved and receives that education and in some sense therapy as well, alongside their bipolar loved one, the chances of success in the long term go up by many factors. So please keep that in mind, and particularly if you're considering having a family member involved in your own bipolar care. Again, sometimes people are a little anxious about that, and understandably in many cases, but if we can develop that support around that individual and educate and provide a treatment track for them in a sense, and to one extent or another, whatever is appropriate, and everybody's on the same page, then the chance for success goes up dramatically. And thriving beyond bipolar itself, so important as to why we have a 3-phase approach. So we'll talk about pre-stabilization issues. This is the first phase. It's usually noted as a crisis caused or worsened by bipolar disorder. And it's not always recognized as bipolar, as we've talked about. So it's important that, that an assessment for bipolar mood swings occurs during this phase in time. And that we expect in this phase of treatment some degree of denial, either in the patient or the family or both. And again, it's not because they're bad or they're uncooperative or so on. It's just really a part of what goes on when you have bipolar disorder, or you have it in your life in the sense that your loved one may be dealing with that condition. And as I mentioned, this is a time about breaking down and treating symptoms and separating the perceived good from the obvious bad, and helping patients and families to begin a conversation about what are the things about bipolar disorder that you would like to kind of get rid of. If we could do that, if we could isolate those things and help you through that piece of it, what can we do about that? And by the way, this is also time to start a medication conversation, which can be a very difficult thing for some people because they very often are afraid of medications, or they either for reasonable experiences in the sense that something happened to them earlier or a family member where medications didn't go well, or horror stories of all kinds that we very often hear in the news or we can read on the internet or whatever, that can make a person not want to have anything to do with medication and try to seek maybe some alternatives that may not be as effective. Very often, by the way, I hear people say something like, I don't want to get on medications because it means I'm crazy. there's that word crazy again. And again, I think it's kind of an interesting concept. That somebody may, at least I know that perhaps it's a reaction and not a very well thought through concept, but it does really reflect a certain fear of what that stigma around mental illness and mental health is all about. And taking a pill or taking a medication or some sort of treatment in that sense for people kind of represents that they're sick and broken in some way. And that's kind of built into that denial, and it's understandable, but of course it needs to be addressed. So interrupting other therapy goals to treat mood swings first. I don't know if interrupting is misspelled or not. You can check that if you want. Maybe it is. But in pre-stabilization, as a therapist, we have to put aside some of the pressing issues, with the exception of maybe something, of course, if a person is actively suicidal, but that's part of the bipolar in itself, or if they have a substance abuse problem, we have to address some of these things urgently. But if they're in for relationship problems, or they're having problems at work or school, or they're having self-esteem issues, and so forth, a lot of those things that they present, we have to kind of put aside and really start to look at bipolar disorder as the primary driver for all of these other problems. Pre-stabilization is also the time to engage family in a bipolar education, identifying the functional consequences of bipolar disorder. As many of you know or can relate to, a lot of people, when they're in a manic episode, they can go on shopping sprees, spend way beyond their means, engage in substance abuse or hypersexuality and sexual indiscretions that are uncharacteristic in this, very often. Not uncommon for somebody to get in their car and drive 90, 100 miles an hour down the freeway, and they just feel bulletproof. They feel almost like nothing that they do is going to bother them or harm anybody else around them. So treating bipolar disorder is really, at this stage, is really identifying what those consequences are and starting to work with that and help the individual and the family to kind of get their mind around the fact that that individual did participate in some of those things. And in fact, it's not uncommon, and sometimes it's kind of looked at as denial in itself, and maybe, but very often people have a fractured memory process in a manic episode. And so they may not actually remember everything that they've done, but other people around them certainly can. And sometimes you have to provide some sort of evidence, if you will, that these things that individual really did occur. Fears and stigma about bipolar disorder diagnosis and treatment. During this period of time, it's really important to look at and address substance abuse and self-medication. I think very often people who abuse substances with bipolar disorder are trying, in some sense, whether they recognize it consciously or not, that they are medicating their bipolar symptoms. In the case of people with mania, very often they want to extend that manic episode through substances, but all, I think, ultimately for the purpose of avoiding the really desperate sense of depression that they may feel in those depressive mood zones. And then, of course, we talked about suicide potential, which, by the way, doesn't by itself go away when a person is no longer depressed or no longer manic. Very often people in the baseline zone can become suicidal. So it's not a safe zone by itself. And that's why treatment needs to extend through those different episodes or mood zones, if you will. Because very often people in a baseline become aware of the things that they've done. And that can really set them back, and they can become suicidal as they become more aware and reflective of some of the damage that may have occurred as a result of bipolar mood swings. So in all of the things necessary to help people move from pre-stabilization to stabilization, I think it really is ultimately a connection that's established with the professional team, with some confidence with the family's support around that individual to say, okay, let's move on and let's see what happens next. And it's not as if we get complete acceptance for bipolar moving into the stabilization phase, but there's some recognition and some understanding that we do have to move forward. And with that trust and understanding among the team members that we're working together collaboratively, we can then move into the stabilization phase, which is the next phase of bipolar care. And what marks stabilization is finding the right medications and accepting bipolar as a lifelong condition and treating the entire disorder. We're starting to weave together some of these symptoms and really treat bipolar disorder in a unified way. Now, finding the right medications is a big deal. And for many people, they may hit on the combination of medications with little or no side effects involved, and great. And it's not necessarily easy, but it's simpler for people that seem to respond well. But for, I think, many more people, frankly, there's some trial and experimentation that has to go on during this time. And so it's very important to stay connected at a therapeutic level and at a family level as people are trying medications and maybe they're not, the first medication or the second one's not working as well. They have to add one. You add one and then sometimes you get a side effect from the other one. You know, it really is at times complicated. But if people stay on track together and there is that therapeutic level of trust and understanding what this process is meant to be, then very often people endure some of that trial and experimentation and begin to feel better and will recognize that they actually feel better. And a lot of people don't right away. You know, some people can relate to kind of going, you know, it made me feel kind of, the medication made me feel kind of numb and made me feel like I can't feel anything at all. But we find that these immediate sort of reactions can be temporary and all part of the process of, from a biological standpoint, of how these medications are starting to affect the brain, but also from an emotional standpoint, the person's perception. If you've been bipolar your whole life, and we know that you are when you have bipolar because it's genetic and you've had it since day one, you know, you're used to feeling typically emotions in extremes. And so when one changes, it really kind of signals another. And sometimes when people are medically going into that baseline zone, they fear that they're going into something else because that's what they're accustomed to. So this is all really a psychological adjustment during this phase as well. And it's important, obviously, for families to kind of get that education and really understand what this process is all about for them as well. And here's some bullet points. I want to point out in particular grieving the beneficial aspects of mania during the stabilization phase. People who, again, enjoy or counted on certain aspects of mania have to go through a real grieving process, I think, and begin to kind of let go of that. Now, what they can look forward to through post-stabilization is kind of a return to an understanding what that creative and process and productivity is all about, but in a more organized and consistent way. And therapy is there to help that individual to do that. But nonetheless, in life, when we lose something that we don't want to necessarily let go of, we go through some level of grief. And that's important to recognize during this phase. The other part too is about, at the end here, beginning to repair the damage of functional consequences, right? And that's particularly within the family as well. And very often family members, parents, spouses, caregivers, and others, sometimes they feel like the treatment process and the loved one with bipolar, it doesn't include them, or they feel kind of left behind as that person may be progressing through their treatment. But they need their pain and their reality recognized. So if you're a loved one, a family member, a caregiver, and so on, of somebody with bipolar disorder, then I think it's important to recognize that your experiences have to be looked at, recognized, honored in some way, and maybe even treated, if necessary, with individual or family therapy. Because what you have gone through, staying up late at night, or wondering if your loved one who has bipolar disorder is going to come home or not, or what's going to happen next. One time they're very active and give you a lot of attention. Next time they're depressed and they're ignoring you. These things can be very traumatic. And I think that family members who receive the kind of care that they need on a sort of a parallel track with the person with bipolar disorder, again, everybody can succeed and own bipolar together in that sort of scenario. And then as medications are noted to be effective with minimal or no side effects, and they're kind of set for maintenance, we're moving into the post-stabilization phase. And this is often the time where a lot of work from a therapeutic standpoint really starts. I mean, those first two phases sounded very complicated and daunting, and they can be. But post-stabilization is about the rest of the person's life. And that doesn't mean they need to be in treatment, therapy the rest of life. They certainly may need the medications for the rest of their life. But they don't necessarily have to be in therapy the rest of their life, necessarily, unless they need it kind of going forward at some period because of a life change. But it does represent the longest phase, hopefully, because it is a lifelong disorder. And we can sort of look at it as a more extended time for an opportunity for that person to really grow into the person that they're meant to be. So you see in the first point, medications are tolerated and effective. So we don't have post-stabilization until that happens. And going forward, there may need to be medication changes. We might have some breakthrough symptoms or something. That doesn't automatically mean that we're going to go back to the beginning. But I think it's important to be aware that for the most part, until those medications are tolerated and effective, do we have an opportunity for the post-stabilization phase of bipolar therapy. Medications are set for long-term maintenance. When I say therapy is more consistent, what that means is that very often in those previous phases, patients and families can sometimes they get afraid about the treatment. They don't like the treatment necessarily. They kind of long for the days of those beneficial aspects of mania. So they may sort of drop out of therapy a little bit, or kind of retreat a little bit back into that fear, into that denial pattern. When I say therapy is more consistent in post-stabilization, because they're moving into that greater sense of acceptance, therapy, and not just in the office with a therapist, but in how they approach their whole life in a healthy, well-balanced approach, becomes a more consistent day-to-day kind of lifestyle. And that's when a person moves from surviving bipolar to really thriving in the goals and objectives that they set for themselves in their life going forward. And I mentioned about treating the whole person during this time, not just bipolar disorder. We're not done with bipolar entirely, but we're entering a new phase where an individual probably talks less about bipolar. I mean, kind of hope so from a therapist standpoint, because we know that we're kind of getting our hands around those symptoms and the treatment needs for those symptoms. But now a person is really dealing with themselves, their relationships, their occupational and recreational goals for their life in a broader, holistic way. And also talking about the kinds of things to help them to be healthier, diet, exercise, and all the things that we're all supposed to be doing anyway. But now in a fashion that is more organized, more consistent, rather than allowing bipolar mood swings up and down to kind of dictate where you are in pursuing these goals and actuating them. And then accepting a new identity apart from bipolar disorder. Recognizing that bipolar disorder is a part of that person's life, but it's not front and center anymore. It's kind of on the periphery. And we know it's there, and we know what we have to do about it with regard to taking medications being vigilant to whatever symptoms may be coming about as that person goes through life changes, medical changes and age and so forth in their life. But the development of that identity is about being a creative person, about being a productive person, and forming their own personality away from bipolar disorder. And a lot of times family members don't like that entirely because they have maybe a vision of what that individual should be. Accepting your new identity is not adopting an identity from somebody else or from expectations around you, but really getting to know who you are and who you're meant to be as an individual. And hopefully family members can accept that too. Pardon me. This commercial break is brought to you by water. There. Almost made it all the way through. But let's continue with post-stabilization. Post-stabilization represents acceptance of the lifelong disorder, but will be tested occasionally, primarily by the next bullet point that you see in front of you. Testing life without meds. Now, when I have somebody who is entering into that post-stabilization phase or has arrived, we always talk about this. And what I always say is that, look, you're doing great with your bipolar therapy. It's obviously working for you. But I assure you that at some point in your life, sooner or later or much later, you're going to consider testing your life without medication. And if you're still coming to see me or you're seeing another therapist in the future, for whatever reason, it's important to bring that to the therapist's attention. And I also tell those patients, look, if we haven't seen each other in the office for an extended period of time for whatever reason, and you're feeling that way, would you give me a call? Would you, bring it to my attention? And I try to ask these things rather than kind of demand it. I think people appreciate the opportunity to say, yeah, I will, or I'm not sure why I have to, or just talk about that issue in itself. Very often I find that people who want to test life without meds probably have another kind of life issue that's kind of pressing that in a sense. But it's not uncommon for people who are feeling pretty good for a long period of time to kind of go, do I really need to do this anymore? And that's not unrealistic. Again, it's expected. And it really signifies, I think, the success that a person has in owning bipolar to that point. But it's yet another challenge of owning bipolar to say, okay, what's going on in my life that I'm thinking about doing this? Sometimes I find that people do try life without meds, and actually it's not like you get off meds today and tomorrow you're going to have a crisis. That person can be crisis-free, if you will, and maybe feel pretty good for an extended period of time. But we would expect that pre-stabilization crisis to reemerge at some point. Because again, this is a disorder requiring a lifelong care. And so people, I don't recommend that people try that, but I know some people do. But when they've recognized that they need to get back on treatment, very often they become even more adamant about their care, recognizing that, hey, this isn't going away by itself or based on all the good things that I have accomplished to this point. It's something inside of me that happens. It's brain related, and you can't just grit your teeth and make your brain do something it wasn't meant to do. But again, very often people in that situation will come back and say, you know what, I need to own bipolar even more than I thought I did. And that's okay. As long as you survive that situation, you can be stronger, and there's never meant to be any shame because you've kind of fallen off your treatment, or sometimes people kind of go, you know what, I got a big test coming up, or I got a big project to do. Maybe I'll just stay off my meds and get a little manic, and then I'll get stuff done, and then I go back on my meds or whatever. It's a dangerous thing, but it's understandable. And again, there's not meant to be any shame in that situation, just an opportunity, hopefully, to just have greater strength and greater resolve in doing this. Then the bullet point there, the third one, is it bipolar or is it me, in quotes, separating personality from the bipolar disease process, if you will. What does that mean? So that's the question that a lot of people ask when they have emotions in that post-stabilization phase. If they get really excited about something or really angry about something or they're sad about something, they're going to ask themselves, wait a minute, is that bipolar, or am I really reacting to something authentically, genuinely that's going on in my life? And likewise, family members will question that individual too. And so we have to work together in post-stabilization to talk about how family members and the individuals with bipolar disorder talk about emotional experiences. And we develop what I call as a grand bargain, which means if I'm the family member, I say, as long as you keep me apprised on how you're doing with the bipolar from time to time, I won't say everything about you is bipolar. And on the other side of that, the person with the condition has to agree to, look, I'm going to keep you apprised on how I'm doing with bipolar, but please don't think that everything that I'm feeling is bipolar related. Because I found that people with bipolar disorder don't like it when somebody says, hey, are you off your meds? Because you seem pretty pissed off at me right now. Maybe there's a good reason to be pissed off sometimes, and so time and opportunity gives the patient and family opportunity to live life in all its various contexts and develop emotional experiences to recognize who that person really is, both from the individual standpoint and then perspective of the loved one. Say, oh, if he or she is getting angry or upset or they're sad, there must be something really going on in their life. It's not just about bipolar disorder somehow influencing that away from whatever that person's reality really is. And then finally, the post-stabilization phase is really about thriving in health, creativity, and love. And in the book, Owning Bipolar, we talk about that with greater detail. And if I could just focus about creativity just for a couple of seconds. Obviously, a lot of people are afraid to kind of give that up because they've relied on bipolar mania to fuel their creative process. And one of the important things to understand is that the creative process is not just about energy. It's about skill, it's about knowledge, it's about experience, it's about other things that may be somewhat personal or individualized about that human being and how he or she sees the world and sees problems from a unique perspective. Those processes are not all embedded in bipolar disorder. Very often we confuse the energy of bipolar mania with the rest of the creative process. And people with bipolar disorder are not all great entertainers and mathematicians and scientists. Indeed, many of them are, as I'm sure you know. But most people aren't. And what happens is that because that energy is, and that sense of grandiosity and euphoria that very often is a part of bipolar mania, kind of fools them into thinking they're better at what they are doing than they really are, okay? So it's important to recognize that if you want to be good at something or you want to be unique and creative, you have every right to be, but there is a process by which an individual has to organize himself or herself, become more educated, read more, take classes, sharpen their skill set to be unique and to be more productive and to achieve things in the way that they're meant to achieve them. And I see this all the time with people who are in the post-stabilization phase that become very successful, very creative, and very productive in what they're doing while managing their bipolar disorder successfully. So there is a great deal of hope available. And I think, again, with organizations like International Bipolar Foundation, with the resources available from loved ones, from treatment professionals, and hopefully, if you'd like to certainly get online or go to your local bookstore and pick up a copy of Owning Bipolar and let me know how you feel about it. If you like it or you don't like it or you've got questions about it, I'm always available to discuss that. Here's some websites. My website is michaelpipich.com, and feel free to go there if you want to just kind of get to know my practice a little bit more and about me, but there's also a link, an email link, if you want to ask any questions. And then owningbipolar.com if you want to know more about the book. And then the Bipolar Network on Facebook is also a place you can get more information as well. So thank you again to Aubrey Good and the International Bipolar Foundation. Thank you very much for joining me today and kind of going on this journey together. And best wishes to all of you in any way that bipolar disorder affects you in your life, one way or another. Know that there's hope, know that there's people that care and that are waiting for you to reach out to them. And maybe together we can all take this 10-year gap in treatment and bring it down to about there. So have a great day. Thank you.
Thank you so much for joining us. That was an incredible presentation. We are out of time for questions. However, Michael has generously said if you would like to ask him something, you may email him via his website, which is showing on the screen. And you are welcome to email me as well at agood@ibpf.org. We wish you all a happy and healthy day, and we will see you next time. Thank you very much. Bye-bye.